Raja, you can take over and introduce.
We are live now?
Yes, Doctor.
Yes. Yeah.
So, good evening, everybody. Welcome to the second session of the ISHK webinar, the ISHK teaching program. We have with us today Trustee of ISHK, Dr. Vikram Shah, Senior Faculty of Pachore, Education Academic Chair, Dr. Dipak Dave, and our guest speakers, Dr. Suryanarayan and Dr. Mahesh Kulkarni. So I welcome you all for the teaching program. First, we'll start with the talk by Dr. Mahesh Kulkarni on hiring officers in DHR.
Yeah. Thank you very much, Dr. Dhanasekar and the ISHKS seniors and stalwarts. What has happened, Dhanasekar, is my computer is still taking a few seconds to complete the upgrade. Do you want Dr. Suri to start, or we could hang on for a minute?
I can do that if necessary.
So I welcome Dr. Suryanarayan to give his talk on Unicondylar knee replacement, current trends and overview.
Yeah, thanks, Dr. Suri.
No problem. Am I visible?
Yes.
It's okay?
Yes, sir. Audible and well.
Yeah. Thank you, Dr. Dhanasekar, Dr. Vikram, Pachore, Dr. Dipak Dave, ISHK. I think it's indeed always a pleasure. And I compliment Dhanasekar for just steadfastly carrying on this academic work. I'm sure all the fellows and the DNB candidates will benefit from whatever we discuss and share. So the subject given to me is about unicondylar knee replacement. There is a little bit more buzz these days about unicondylar, but not that it has been not there. But the key to success of any procedure is basically has to defining what the pathology is, what the problem is, at what stage it is, and then plan the appropriate treatment. It could be that always is sort of a functional gap. It could be right from which we talk about arthrosis of the knee. It can be from scopy, debridement, variety of conservative preserving procedures to osteotomies to unis to the total. But any sort of an arthroplasty, one must bear in mind right at the beginning is it's the last option which we consider. And then plan the exhaust all the preserving, conserving possibilities before you consider anything. Unicondylar replacement, if you see, has always been a flip-flop. At one time, it suddenly came into existence. Then as the total knees became more popular,
Recording in progress.
the unis started becoming less. Yes, a voice echo. Yeah, so the unis became a little less popular, and then and there was always a competing space between whether to do tibial osteotomies or unicondylar. It did change from various geographies. And then, like, for example, if you see the Europe, it was more towards tibial osteotomies as much as possible. But at the same time, the unicondylars were much more there. United States has picked up at this time a little more, but it was not very fashionable or very thing which was being done there. If you look at also the various registries, arthroplasty registries, like the Australian registry, what do the recent trends say? Basically, if you see, unicompartmental replacements increased a bit somewhere around the 2014-13. And what we found was also the pattern and the distribution of the indications became sort of quite different. If you find the proportion of males undergoing uni knees were much more, and the proportion increased by about 5% since 2007. But if you see also uni replacements overall, in the entire decade and even now, the total percentage of indications of the overall arthroplasties done in the knee stands only at about 8 to 9%. And one has not seen any significant increase in this. And this is the data even at 2021, the Australian registry. What he says, primarily the unicondylar knee surgery, the patients typically in the 60s and the 70s, monoCompartmental problem. They are a little younger if you look at the problems of isolated patellofemoral, but a little older if you compare with the total knee replacements. So now coming straight to the point, that was just about the demographic issues of the unicondylar and the back and forth what has been happening. And there are many reasons for that also. As we do more, we learn more, we see more, and the possibilities have been increasing. The present day approaches, I think we will discuss in this next 40 minutes is the indications, the designs, the techniques, what we do, what has changed, and the use of technology, which has probably made some little bit of changes in terms of acceptabilities. We should also discuss the issues and the outcomes, what to do, what not to do. If you look at the various alignment issues which we discuss at every meeting and everything, which is also in the literature, what we find the most sort of the kinematic or the constitutional alignment is the unicondylar. For two reasons. Every one of us is bestowed with a certain pattern of alignment. And since unicondylar involves only resurfacing of the cartilage, in fact, it should be called the resurfacing of the partial resurfacing of the knee. It's a procedure for the eccentric cartilage erosion. So it doesn't change any way the overall alignment, and it is not our endeavor. I think this is a point all of you have to bear in mind. We do not change the alignment with unicondylar, but restore what it was before the wear of the cartilage happened. The classic patient selection, if you see today, I think most important when you see a person, they look at the history, location of the pain. Are they able to put the finger right to the point on the medial joint line, which is tender? Physical examination is important. Pain predominantly should be only in the medial compartment. Occasionally, there may be some sort of a medial patellofemoral pain, and the varus which you see should be a correctable varus. You should be able to restore it to the neutral axis when you do the stress valgus test in this case. Clinically and radiologically have a rough idea about whether the anterior cruciate ligament is functionally intact. Mind you, the word functional, because you do the clinical examination and that's what you will have, that whether you have a drawer sign, whether you have the Lachman which is positive or not. It is not really mandatory to do an MRI to decide this. If it has been done for other reasons, that's another matter. Preferably, probably the uni could be considered in people who do not have a significant deformity of more than 10 or 15 degrees. But this should be correctable because it has other repercussions. We'll come back to later. So in short, if you have to summarize, unicondylar knee is an indication for non-inflammatory degenerative joint disease. That is what is called anteromedial osteoarthrosis. The anteromedial osteoarthritis came into vogue in the discussion, which was early on published by Yagi, one of the surgeons from Japan, where the erosion of the cartilage when you open C is only in the anterior half. As it progresses towards the posterior side, you find the incompetency of the ligaments, especially the anterior cruciate walking in. Second major indication could be the avascular necrosis, focal avascular necrosis, like a Sonk lesion or probably areas of cartilage which may be involved. One could debate whether it should be reconstructed with the cartilage preserving procedures. Yes, of course, it's an option, but uni probably would fit in if the patient is of that type of a constitution, where you find that is not other regenerative procedure is not going to work. And basically, second helps in the correction of a painful deformity is a varus with the erosion of the cartilage, and you have sort of a lurch, you can consider this procedure. So this is classically the picture which you find on the table. The lateral compartment is totally intact. You find the totally eroded and hibernated anterior sort of a femoral cartilage on the central area, which is the point of contact. And that's what you see as the bone on the X-ray. And this deformity should be correctable. The other one which you see on the cell is a small Sonk-like lesion of varying degrees you may find. There is a hyperemia that surrounds it, like you see on the MRI picture. Treatment, of course, is not that immediately you jump to the uni. This is one of the pictures which you may probably be keeping it at the back of your mind, but try the medical management, try all the other things before you consider the anteromedial. Deciding on sort of whether unicondylar is a feasibility or not does not depend upon one X-ray. Your X-ray lobby should be like this. You will have to have a proper scanogram, the proper AP and the standing lateral, and also it should contain the patellar tangential views and a stress valgus correction picture. Once you have these X-rays, you get a broad, good idea about the cartilage situation. There are many things you can evolve, like the Oxford group who mentioned that you get a lot of information. One, about the correctability with the stress view. Two, about the patellofemoral situation, whether the cartilage is good, whether it is tracking central and well, and that is not the source. Third, when you see the lateral picture, if the femoral tibial articulation is central, it is more likely that the anterior cruciate ligament is intact. This is a surrogate way of confirming whether the ACL is good or the ACL is bad. The AP X-rays, of course, give us also the picture of how the lateral compartment is. For example, this was a 47-year-old male, meniscectomy done, severe medial joint pain, full range of motions. He was a policeman. Probably you would consider whether he needs a osteotomy or this. But look at the MRI pictures. The ACL was just not visualized. Clinically, though, no significant instability and no functional issues. Probably this candidate is probably on the borderline. Probably in this case, you should more veer towards an osteotomy or a conservative procedure based upon the pain and symptoms rather than jumping to uni. Young man, very active person, probably uni may not be a great idea right at the first instance. Do not even consider when you have a joint space which can be seen well on the X-ray, you have to have a bone-on-bone situation, and at most of the situations. For example, in this case, that was the status of the cartilage. This picture needs something else to be done. It is not AM or unicondylar. It will not work. People done at this stage have never been happy. So be very wary of it when you have still an effective joint space that is seen radiologically. Think of all the other possible causes from the cartilage, from the meniscus, from the other intra-articular structures. Unicondylar is not the surgery of choice in this case. Again, to reiterate, bone on bone is very crucial before you decide upon this. What is your endeavor? What are you planning to do when you want to resurface one half of the joint? You are trying to get what the picture, like the left side, it is the correction valgus picture, and you will try to recreate the same axis, the same alignment, the same joint space thickness, both on the lateral and on the medial side. That is all what you do. You don't touch any of the ligaments. You don't touch this. In fact, we had studying just for information that we studied the status of the ACL. This is usually graded and published as of 4 grades, whether you have a normal looking ACL without any fibrillation, pure synovial damage, or probably it is having multiple longitudinal splits. This is in terms of a structural identification and assessment. Of course, like I said, functional would be the assessment of the drawer test and the Lachman and other things. You find most, and then we looked at conventionally how these patients behaved post-operatively. That did not seem to be any big difference. But when you have a stage 4 or absent, I would not personally suggest, and nobody should probably venture out in this case. The reason for putting this was these days there is some discussion whether the indication for the unicondylar can be extended for partially deficient ACLs from especially the knee conserving and the arthroscopic surgeons. This comes from the experience which has been derived with osteotomies with ACL deficiency, where you change the slope of the tibia, and then you can probably try to counter some of the negative effects of an absent ACL. Just to bear in mind that this is sort of not a very subject which we can give a blanket answer, but just for the knowledge sake for the postgraduates and the fellows, I think this is necessary. So ACL integrity on the table, you can also assess by what is called as the hook test. Just put in a small hook from the hand surgeons or the small sort of a reconstructive hook, and then you see whether it is having a good endpoint. If you have a good endpoint, both distally and proximally, I think you are safe. This is a counter second check which you must do on this case. The importance of anterior cruciate ligament and unicondylar comes especially in 2 ways. One, if you choose a design which is a mobile bearing, and other one when you do the fixed bearing. Fixed bearings to some extent can to some extent spare an ACL insufficiency. But mobile bearing certainly requires a good, functional, robust ACL, at least at this time. For an average discussion, I think ACL is mandatory. A good ACL is mandatory for the mobile. It could be a little sort of a thing compromised, and one could think, but I would not suggest, and this should not be done by the beginners. People with significant experience, they can consider this possibility. Otherwise, I don't think it should be gone. What is the role of the patellofemoral joint and the patellofemoral symptoms? 8 out of 10 patellofemoral symptoms, pictures you find on the table, that is erosion of the medial facet. But what is very necessary for you to properly assess on the lateral side, the lateral cartilage should be intact. If that is showing fibrillation or significant destruction, reconsider your decision. Point number 2, if the patient considerably complains of pain on the medial patellar facet, when you sublux and try to feel for pain on the undersurface, if it is significantly positive, again, you should think twice before you immediately jump in to a diagnosis and a treatment as unicondylar for these patients. Some small kinematic considerations when you talk of uni, some points which you can also keep in mind. What is important is that we are talking of the elastic gradient, which is now changing because you have resurfaced one side with the metal and the cartilage versus the cartilage entirely on the opposite side. The non-involved lateral component, if you overcorrect, will take 60-65% of the stresses, unlike the medial side, and that will lead to progression of the cartilage disease. This happens basically because of the elastic gradient between the cartilage and the metal. Hence, this is for this reason, to avoid this, you want to slightly undercorrect when you do a surgical treatment as unicondylar. There is second, what is called as the adductor thrust. And this adductor thrust is adductor movement. You have seen a lot of people walking with a little lurch and walking into your office. And this adductor movement, if there is less, it is 100%, I think, a good kinematically sound clinical indication. If the adductor thrust is very high, unless at situations, I think that is not a great situation. So tall, thin individuals, especially males with narrow pelvis, are great indications in terms of kinematic. If you have a short, stocky lady with a wide pelvis, short height, probably you should worry about this, because for the reason that they are not great candidates in the long term. The reason why it comes again is because of the adductor thrust. See, like this lady walking. There are 2 points I want to mention. When they come like this, you can do all your radiology if everything is occurred. But please look out for 2 points. If there is any subluxation, I think one should be very careful, because this can be a problem in these cases. Second, if the lateral side opening is much more than the normal dimensions, be wary of it. Because this would have led to the opening up and the what is called elastic deformation on the lateral side with stretching. And even though you may correct the medial cartilage, she will tend to go on to the thrust again because of the mediolateral translation that will be permitted because of the lateral side elongation of the lateral ligaments. So I think this is a point you should consider whether to offer there or not. Most often you'll find the subluxation totally corrects when you probably do a stress X-ray. But if the lateral opening is more, please be careful. Some crucial points about the cruciate surgery. Unicondylar is not a soft tissue surgery. Soft tissue release is totally never a part of uni. Principally, you are replacing the eroded surface and the thickness of the cartilage. Hence, the varus should be correctable, and you will line up the femur on the tibia with a slight undercorrection. 2 millimeters of sort of the opening on the medial side is very much desirable, but we'll come to that. That also depends upon the design. Unicondylar replacements are highly sensitive procedures to alignment. Slight undercorrection, I'm over and over again emphasizing, keep it about a degree or 2. There are some debates coming off late whether to put it in the neutral thickness, but that's for another day. Overcorrection leads, like I mentioned, accelerated lateral compartmental disease. Your dissection entirely should be totally restricted only to the deep tibial, above the deep tibial level. You don't have to release. All you do is expose, dissect all the osteophytes, both on the medial tibial and the femoral side. Assess the lateral compartment. I don't want to put this video because I don't think it will be explaining anything more. Make sure the ACL is intact, and if it is good, I think one could probably proceed with the surgery. So I think the potential problems which probably one should be wary of during the procedure as such is often the failures, and the problems come because of the cut in the tibial alignment. Eccentric tracking, that your tibial excessive varus cut is a problem which should not be, it has to be avoided. If the femorotibial tracking is way too medial, I think it leads to edge loading, totally avoidable. Do not lengthen and overstretch the medial side, because that has an impact on the lateral side, because it will change the valgus angle and the lateral cartilage will start eroding much more. Second, when you take what is called the vertical socket, I'll come to it in a moment. I think this can be a point of concern at times, and do not do any deep tibial dissection in these cases. So vertical, getting a little bit of a small tibial vertical cut to take out the hemicondyle of the tibia is one part of the procedure. And when you do this, if you always stick to the surface and be perpendicular to it, if you go at an angle, what happens, your deep tibial cut tends to go more distal than required. And this more distal beyond the tibial section, that cut could be a stress raiser leading to a condylar fractures. So this is a point one needs to keep very much in mind when you are performing the procedure. And also, when you keep the depth of the tibial cut should not go more than about 4 to 5 millimeters. And to avoid this, what one can do is then retain the blade which you do for the transverse tibial cut, so that that can act like a protector for your vertical cut. This is one sort of a small surgical tip which you can do. So when you do this, keep the other blade below also intact and then proceed with the procedure. But despite all this, in these techniques, often it probably is a challenge to obtain exactly the precise thing. In the overall long studies, it has been seen that the outliers beyond about 2 degrees has been seen in almost about 40 to 45 to 50% of the cases. And this is published data. But I think one has to make an endeavor to get, like how we do in the total knee exactly, I think you should get it down straight into the center. This comparison between the fixed and the mobile bearing with regard to the cut, it is seen that in the mobile bearing, fixed bearing, like I mentioned, keep 1 to 2 millimeters of laxity. But in the mobile bearing, you would not want to do that. That is basically because otherwise, if you keep it too lax, I think the bearing spin-off is a big concern. You could take the lateral Fujisawa point like we see in this case, or whatever is your alignment idea, bring it down to the ankle, the same, the other things do not change, and then plan your cut. But one important probably thing is a little laxity helps, but probably plan to align your cut to the native epiphyseal angle. This will prevent you from overstuffing. Study the X-ray closely. If some of the people have a 87, 85 or 88 degree varus tibia, then you don't have to have an exact 90 degree cut. You can get the tibia into a degree or two of a varus, almost like what we do in the kinematic alignment or a constitutional alignment. So 2 take-home points here is, on the fixed bearing side, keep a little bit lax. In the mobile bearing side, you will get exactly the thickness. But very important, if you can align the tibia to the native epiphyseal angle, that will be a good bone. And the correct placement. Other mistakes which we do, which often is that the sizing, the mediolateral placement. These I've just taken the screenshots of a procedure with the navigational aids, just to say that you have got to stay within. The dots which you see on the articular surface here, they should be articulating more towards the center. When these things go towards the medial side, when you do the arc of movement, then you are eccentrically loading. 2 problems in this case. One, eccentric wear and lift off of the tibia, and that will lead to the tibial loosening much faster. So these are the points you will also do when you do the conventional procedure. The same thing, that you should have a central orientation and the central articulation of the femoral tibial point. Second important point is about the tibial slope, which you recreate again the parent or the native tibial slope, which is important. So the points important so far as the procedure is concerned: joint restoration of the joint line, the depth of bone resection, the tibial slope, centralized placement of the tibial and the femoral component so that your articulation is more towards the center. And then you make sure you are balanced and slightly undercorrected or well-fitting. The mobile bearing implant should snap fit inside. You should not be able to place it very easily, which means that probably it is not right, and maybe you may have to take a size bigger. Do everything correct. I think even with the most conventional implant, this is one of the things which we had done about 20 years ago, and is still actively doing, with the other side still not responding. So basically, when you resurface the cartilage and do not overload the lateral side and ensure the stability, the function happens to be excellent and for a long, long time. There are some problems. I would just want to show the pictures what we are talking about. This is a case of clear over distraction. If you see that the lateral area, I think it is totally opened out. What probably could have been the cause? If you look at it, the lateral side was already subluxating. It had opened up more. This is what I was telling you before. Now, to compensate for the lateral stability that a person has put, and the person was me. I put a much thicker poly many, many years ago when we did not realize this, and this leads to problems. So this is not an exact excellent recreation of the anatomy or the kinematics here. Over-lateralization in this problem, in this case, is another problem. This, when you have a picture of this sort, of this picture, what you find is that it starts impinging towards the tibial spine, and this will hit the anterior cruciate ligament fibers, and functionally the patients do not do well, and this could fail much earlier. So this is another point. You should stay more lateral towards the intercondylar notch, but not encroach into it. Sometimes in a very small sizes, you may need to go, probably you can take about 20% or 15 to 20% of the fibers of the ACL can be infringed by just releasing it and trying to work under the tibial spine. And that is one sort of a technical strategy which you could use. The tibiocondylar, also, if you do not take out too much of the tibia or distalize the femur, you change the joint line, asymmetric joint line. So I think the femur is the crux here. It has to stay perfectly exactly in that same spot where what you take out, it should be put, and then you create a straight cartilage line, then it works well. So this is another point which you should be very aware of. Avoid eccentric joint spaces. Nothing changes whether it is fixed or the mobile bearing, but for the instrumentation, I think today the microplasty instruments, I'm talking of Oxford because that's one of the most well done and most popular worldwide and done in large numbers. The only difference is that since it is very technique sensitive, I think one should be doing these procedures a little more regularly. If you do once a year or 5 times a year, probably we do not do a great job of it and end up with a lot of problems. So at least about 5-10% of your technical procedural volume, if it is Oxford, I think it is good. Technically, this is very demanding, has a steep learning curve. Probably one should take aware of this and take help or take the help of experts before you do the first 10 or 15 cases. The same thing can happen even in the mobile bearing. A varus cut is not tolerated. Here, if you exactly what I was trying to tell you, you have a varus cut with a medial point of entry, it just lifts off. It just fails. One needs to be very, very careful. This was a over varus cut, thinking that this was probably a native varus of the patient, though actually this probably was a wear and it was a neutral axis of the tibia. So you need to properly align and decide the epiphyseal angle of the patient. If you have excessive distalization, it's too much of a femoral thrust on the distal side. This again, over a period of time, elevates the tibia like you see in this case, and subsequently went into loosening and had to be revised within about 5 years. What does the literature say? Analysis and treatment of complications of the unicompartmental. If you look at the mobile bearing with a multiple meta-analytical studies, the predominant problems seem to be bearing dislocation or a progressive instability. And aseptic loosening about 23%. This is a report that came from Korea by the Independent Center. And the revision, of course, 50% of the time because of they could change just with the polyethylene. But probably it's not a poly wear as such, I think more than the instability creeping in over a period of time. But if you look at the originators from David Murray and the Oxford group, they looked at 8,000 cases of the phase 3 implants and the procedures. And their opinion was, it appeared to be a good or long-term outcomes, both with the designer group and the non-designer group, so long as the procedure is done well. But again, if you look at the complications in the long term, it has been dislocation, progression of the lateral compartment, and then the aseptic loosening. So I think this is the problem which we see. Properly done, they work extremely well. In terms of functional performance, I think both the medial and the lateral do perform very well. Functionally, there's no question about it. There's no big difference. But if you see the outcomes and the revision rates, I think they have still not significantly come down. By 10 years, the fixed bearing, that's about 9. The mobile bearing seem to be having a slightly higher revision rates. This is a registry data, so I think we'll have to take it from that angle The previous report probably was from the high volume centers, both from the originator and the non-originator. So I think this is a point that is still being debated. We still have to see. The jury is still not very much out. Sorry, apologies. If you look at the EFORT opinion consensus study about unicompartmental, there's a high rates of failure mainly observed in the early phases. Less than 5 years, if it is a failure, it is mainly technical. Patient selection and the techniques. If it is much later than that, beyond 5 to 10 years, I think it is the same, where it may be a septic loosening, it may be a wear in the fixed bearing. But today with the modern bearings, with the modern polyethylene, I think the wear-related problems are going to be much less, even if it is fixed. So realizing that if it is a technique-sensitive procedure, that's the reason I think today, since we are talking of the current trends, the improving precision and reproducibility, what we find that the aids, very precise instruments like the Microplasty 4 in the Oxford or the use of robots have enabled us a great deal, because it helps us to perform the procedure virtually before you take up the final. And this continuous improvements both in the design, techniques, technology has changed the way we look at a unicondylar today. So predominant failures are technical, like we discussed, the varus cut, increased thickness of the tibia, medial placement, poor slope. All this could be avoided probably if you have additional help of planning and visualization before you even make the first step. So there are many publications that are coming recently to say that robot-assisted procedures are seeming to be doing better, and they are able to prevent the distalization of the joint line. They are able to prevent the typical varus cut unless you have deliberately planned for the varus. So I think in many of the deficient problems or the reasons for failure, technical reasons that were deficient, robot seems to be helping us a little more. And probably that may be the reason why the tendency towards using the technology and aids for the procedure has been increasing. So coming back to conclude, classic patient selection today has not changed. It has not been substituted. One should not change. A good history is very crucial. Location of the pain and identification of the zones is very important. Make sure there is no lateral compartment pain. Make sure there is no lateral side patellotomies and or significant patellofemoral symptoms. Corroborate and finally confirm also on the proper radiology. One X-ray is insufficient. A proper study is very crucial. Physical examination should also assess the stability and the integrity of the cruciate ligaments, the other compartments, and the correctability of the varus deformity. If there is excessive thrust or if the excessive subluxation, may be wary of it. Look for the thrust and the degree of subluxation and the lateral side opening. Radiology, deformity less than 10-15 degrees in both the sagittal and the coronal plane probably is preferred. Don't take fixed varus or a fixed stiff deformities with 10 and 15 degree flexion. This is a very good procedure if you are following all the rules of the game. With elderly with monocompartmental pain, it becomes a very small operation. These are slightly extended. We do more and more. It's not a procedure reserved purely for the young. Small operation, they recover well, they address the main issue, and the relief and the symptoms are good enough for their level of needs. If you have a metaphyseal or epiphyseal-metaphyseal varus, these are the poor indications. Never you should do a unicondylar in these cases, or consider either an osteotomy, or if it is severely painful, maybe a total knee properly done would be a better answer in these cases. Since tissue release is not part of the uni, you cannot correct this sort of a metaphyseal varus in these cases. So whether you do unicondylar replacement with the fixed or a mobile or the robot assisted, it is very selection sensitive. Patient selection is very crucial, technique sensitive. So you should be rehearsing and practicing this much better. I think if these 2 points are driven home, we have achieved the 45-minute talk benefit. And more useful, effective in this sensitive procedure, the use of technology seems to be helping us more control the the depth and other things. That's today. But also, contrary to many reports, I think there are several enough reports in the data and in the sort of a registry and also independent large center studies. The survival rates at more than 90% at 10, 90 to 93 at 15. And of course, a couple of originating centers have shown even 20-year results at a long time. 2021, what are the changing trends? Like we said, the disease and the disease process is better understood. Irrespective of the technique, the precision is what is crucial. A lot of attention needs to be drawn towards the patient selection. And if it is possible, if you have the feasibility to use technology, I think that is a game changer today. And whether if you do a fixed or the mobile bearing, I think outcome by prosthetic characteristics, they are more or less the same, and it doesn't change much. I thank you for your attention. I think if there's any questions, I'm happy to share and answer.
Sorry, by the time the question comes on the chat, to do ACL reconstruction and uni, is this really asking too much, or is it worth advising, advocating, or we should refrain from that?
We should refrain from at this point. I think these are extended indications even in the best of the hands. And then, so I think for the average, all of us who are not much initiated and who have not been doing big numbers, I don't think we should do. Because the results of total knee today are as good and equally good in the long term. Why take something which is given to chance? So I would not be a person who would probably recommend at this point in time. For anecdotal cases, one or two done for other reasons, that's another reason, but not in general. There are some questions on the chat box. Should MRI be routine preoperative indication for selection of the patients for uni? The answer is no. But if it has been done for some other reason or previously, it is fine. But you don't have to chase it. If one has done enough a proper study of the X-rays, proper clinical examination, you get a lot of information on this. But mind you, 95% of the times you would be right, but there will be always a small percentage. Sometimes you are in for surprises. Subchondral bone stock. With regard to that, the subchondral bone stock, I think is not mandatory. Very osteoporotic bones, please be careful. Most of the time, if it is monocompartmental pure disease, because of a prolonged walking on this. Am I audible?
Yes, sir. Yes, sir. No, it's okay.
Yeah. So, the second question was, what would be the choice, H2 or uni, for a 42-year-old athlete with isolated medial compartment and OA with mucoid degeneration of the ACL on the MRI? Again, the functional, if the mucoid degeneration of the ACL with thickening of the ACL has led to deficiency in the flexion, or if they have pain on the other movements, more on the rotatory movements or in the varus valgus, reconsider that. Don't rush. But what is important on the table, you may have to make a decision. You should keep the both options ready with the patient. If the patient is highly physically demanding, like I would probably go near towards an osteotomy than an than a unicondylar replacement.
So can you do uni if clinically the patient fits into classical AMOA, but the uric acid levels are constantly high?
In the obese patients?
High uric acid level.
Yeah. No, any metabolic derangement, I would desist. Because what you may be seeing is on the medial side, but if the uric acid has been a fresh onset and no other comorbidities, it's a different story. But if it is very high and he has other metabolic issues, probably the cartilage probably has involved even on the lateral side. I would take it with a pinch of salt and be very careful before I think of the partial. There is a question that is coming, can UKA be indicated for obese patients? There is a meta-analysis done and that has been published that the weight does not seem to be an indication or a factor for which we should not be offering the uni. That is the consensus sort of a statement that is made, but I really don't have a very emphatic answer since I've not done many of the very obese patients. Basically, if you see, especially if they're short height, or if you're around 5 feet, 5 feet 2 inches, these are ladies, and if you have the wide pelvis, the way they walk and they sway, you are concerned because, like I've always mentioned, the thrust on the lateral side seems to be considerable. And that's why, again, less possibility for uni than for the total.
Suri, your thought on bilateral uni?
That's not a problem. That's not a problem. If both are indicated, not a problem. And they should be adequately symptomatic. Just because we the X-ray, there's no need to rush. You can always do one, let them mobile, move, see around, let him come back for the other side. What's the hurry in that cases? Because it's a conservative procedure.
Sorry, the Oxford group has published a series in obese patients. They say obesity is not a contraindication.
Correct. That's what I said. Exactly. I'm saying that same thing. It's not a contraindication. But personally, we have not done a significant big number of obese patients. My concern always has been we are talking of a Caucasian obesity and an Asian obesity. Caucasian obesity, you can find a very thick, tall, bulky ladies and a tall height, 5'6" and 5'7". And there's sort of a whole, so morphological makeup is very different to the short, stubby Asian obesity. So I think we have to reconsider, and maybe we should look at it in a slightly different prism and then worry about certain other aspects.
Suri, can I?
Yeah, of course.
Yeah.
You should correct me.
So, Indian patients have a little bit of metaphyseal varus.
Correct.
And tibias are small. That is the reason we are seeing a lot of complication on the medial side of the tibia. What should be your caution to the young surgeons?
The thing is, just because you find only the medial side is involved, don't jump into the thought process. Look at, like I said, look at the stability part, look at the patient makeup, look at the sort of demands of the person. And also, the cruciates should work well, and that should not be sort of a rotatory subluxation in these cases. The second, sort of re-emphasized again, if the lateral side opening is much more than the normal lateral side thickness, I would be wary of it. The metaphyseal varus, again, this should be, if it is correctable, leave it, and then you can proceed with this. If the varus is not correctable, then worry about the metaphyseal. Often the problem you find is in the males, in the varus. When they are very tight and you try to open up by just slightly releasing some more or something, probably it's not a great situation. So be careful whom you are talking or whom you are seeing. Women, again, subluxation is the concern. Men, tight metaphyseal varus. But if the correctable metaphyseal varus, no lateral cell involvement, good ACL, not much opening lateral, I think you can proceed with the uni.
Secondly, Suri, this osteonecrosis.
Yes.
It's a difficult condition, actually. I think the technically, we don't know how much is the femoral condyle has got the osteonecrosis. And that may be a difficult to judge this patient.
One situation where probably MRI is very useful to get the subchondral bone and the extent of the proximal subchondral lesion. If it is active with hyperemia, I think one should not do the procedure. Wait, buy time, by other things. Let the whole thing cool down, settle down, see what bone stock you have, and then you can consider. But if there is a big lesion, more than 7 millimeters, you have got to graft it inside. I think that is again for the experts to do. At the initial times, I don't think one should envisage on that. And if the patient is young, probably conservative options, for example, cartilage repair with corrective defunctioning osteotomy probably would be better.
And very thankful, Suri, that you mentioned very clearly regarding a patellofemoral examination, because if the patients are really symptomatic on patellofemoral, getting down from the chair, getting down from the stairs and other things, these are the patients are not good because that pain is not going to go, Suri.
Correct.
And thank you for your advice that clinical examination is extremely important for this group of patients.
I agree.
Is there any age cutoff for uni? What is the lowest age you have done?
I look at always the possibility of probably you should consider osteotomy. That is a space where we are competing between correction and this. More and more, I think they are going towards a correction of the osteotomy. I mean, properly done, where it may be a bifocal or a unifocal after a proper study. Average, I think in the women, you find that you are able to, you are compelled to get in around 50, 52, probably the youngest. The oldest is in the 80s. That is very elegant because a small procedure up and about, they are mighty happy.
Okay, I think.
There are some more questions. I'll just keep typing the answers. Mahesh can start.
Yeah, thank you. Thank you, Suri. Thank you very much.
Yeah, my pleasure. I hope there are some points I've gone through.
Yeah, extremely well, Suri. Very mature talk.
Do you want me to start?
Yes. Yes, Mahesh, please.
Yeah, thank you very much, ISHKS education team, for allowing us to present this talk on bearing options in hip replacements. Thank you, Dr. Pachore and Dr. Vikram Shah as well. And thank you, Suri, for taking over as my computer was playing up. So what we need to understand is there is a constant dilemma in our minds that whether we should go for a safe, older, and a clinically validated technology to be offered to our patients, or we should look at new options constantly with the possibility of improved outcomes, but there might be potentially harmful side effects. So I think that is what I think one needs to decide before choosing a bearing option for your patient. Now, why do we talk about bearing options? Basically, we worried about osteolysis. Majority of the patients' failures are currently because of infection, osteolysis, and dislocation in hip replacements are the top 3 causes. Can we prevent osteolysis? Can we improve the wear resistance of the polythene? Or we can avoid polythene completely and utilize alternative bearings. These are the options in front of us. There are new materials which are available for articulating surfaces. There is cross-linked polythene. I'm going to talk about extensively about that. Metal on metal, I'm going to touch upon. And then we're going to talk about ceramics, both ceramic on ceramic and ceramic on XLP, and then ceramicized metals, which is the oxidized. Now, what are the advantages of cross-linked polythene? It has got a very high wear resistance. There is obviously no toxicity like metal on metal. There is relatively lower cost of polythene as compared to, say, ceramic on ceramic. And you can get multiple liner options. You can get a lateralized liner. You can get an elevated liner. You can have a captive cup. So there are a variety of options that you can have with polythene. What are the disadvantages of a highly cross-linked polythene? You will have reduction in the material properties of polythene. The yield stress, the ultimate tensile strength, the elongation to break are affected, and the bioactivity of wear particles might be slightly higher with highly cross-linked polythene as compared to a standard polythene that we talk about. Now, if you see this chart here, what you need to do is you need to, on the left side, need to see the head size, which as the head size increases, the function improves as well. And then on the bottom axis, you can see where the high wear is on the left side and the low wear is on the right side. So as you continue to increase the head size to an extent, you will get better function, you will get lower wear. That will give you optimized function, increased stability, better range of motion, and probably maximize your survivorship if you use highly cross-linked polythene. You could not, the red is in highly cross-linked polythene, the gray head diameters are in metal on standard polythene. So if you see, if you use highly cross-linked polythene, we can slightly use bigger heads, the wear pattern is less, the function for that patient is better as well. So we need to understand now, currently in today's day and age, I think a standard ultra-high molecular weight polythene is probably very infrequently or never used in hip replacements. So what is cross-linking? Is the formation of a chemical bond between 2 adjacent chains of polythene. So you get 2 chains of polythene, and with reaction either with gamma irradiation, you can create cross-linking between these 2 chains. And once you form cross-linking with these chains, there are bonds between these 2 molecules, and that produces a highly cross-linked polythene. But at the same time, you create some free radicals. We'll talk about that as well. So what is highly cross-linked? So if you have a gamma inert sterilized material, it is mildly cross-linked if it is subjected to 2.5 to 4 megarad of irradiation. About 5 megarad of irradiation is considered highly cross-linked polythene. So any polythene which is above 5 megarads is probably considered highly cross-linked polythene. What can be used? You can either use gamma irradiation or electron beam irradiation on the polythene itself, which will give you better cross-linking. So you can see comparing between gamma irradiation and electron beam irradiation. Gamma irradiation is slower process as compared to electron beam irradiation. There is less of a control dose with gamma irradiation as compared to electronic beam. But gamma irradiation will have lower levels of cross-linking than electronic beam irradiation for the same level. And you need to understand the more the cross-linking, less is the wear for that material. So once you subject that ultra high molecular weight polythene to either gamma or electron beam irradiation, you get cross-linking, but at the same time, you create some free radicals. So what are these free radicals? These are unpaired electrons which were created during exposure to radiation. They were necessary for creation of crosslinks, but not all free radicals can react with a neighboring free radical. And some of them are left as residual free radicals in the material itself. And unfortunately, these free radicals are quite highly reactive to oxygen, which is present in the body fluids, tissues, and in the environment. So when there is oxidation of these free radicals, what happens is the molecular weight and the chain length is decreased, the mechanical properties are decreased, and the wear resistance is affected as well. So oxidation of those free radicals is bad news. So what can you do to remove these free radicals? So you subjected the polythene to irradiation, you created cross-linking, but we have created some free radicals as well. Now, if you leave these free radicals, they are going to oxidize and they're going to create problems. So the polythene that we use will have one of the three methods that we're going to talk about, which will take away these free radicals. Not completely, but to a great extent. So the first method that we need to understand is annealing or submelting. So what are the pros? So annealing, what happens is subject that material below the melting temperature 2 or 3 times. So that takes away the free radicals, which prevents oxidation. And because the metal, the polythene has not been completely melted, it preserves its mechanical properties to a huge extent. Okay, so that is very crucial. So what are the annealed or submelted heated temperature polythene that is available to us? For to understand, I take the exams because they get used to just banging in implants without understanding the importance. So the polythene that is available in India with annealing is X3 poly, which is made by Stryker. What about remelted polythene? The remelted polythene is the material or the polythene is heated to a very high temperature. The metal completely melts away. It takes away all the free radicals. But however, it will affect the mechanical properties of the material. So the yield strength will decrease and there is greater degradation of the ultimate tensile strength as compared to the submelted or annealed polythene. So these were either annealing, which is submelting 2 or 3 times. Remelt is increased heating massively so that the free radicals are taken away. And the third method is use of antioxidants. So vitamin E is one of those antioxidants. So if you infuse vitamin E inside the polythene, it will trap the free radicals and it will not leave it free for reaction with oxygen. So I think that will preserve the mechanical properties. At the same time, it will not allow the free radicals to react with oxygen. However, elution of antioxidant is possibility, and these elutions might affect the the bearing surface wear. So we still have to look at what is going to happen with those. So if you increase the radiation dose, the cross-linking increases, it increases the wear resistance, and it decreases the wear rate in both hips and knees. Mechanical properties, I'm not going to go into thorough details of mechanical properties, but increasing radiation dose will actually decrease the mechanical properties and it will make the material a little bit stiffer. And increased stiffness of the material means that it can break, it can become brittle. So you need to understand that as well. We know that we have talked about this submelting and remelting. And if you see the submelted polythene, the mechanical properties are much better as compared to the remelted polythene itself. Now, why do we talk about cross-linking? The primary concern obviously is wear debris and osteolysis. And we're worried about the immune response to this wear debris and the particle size, shape, everything matters for it to stimulate osteoclast and cause bone resorption. So we should also not only think about cross-linking of the poly, but we should also think about reducing the number of particles which are generated. So if you see cross-linking and wear debris, you see that there are 4 different types of poly. against a cobalt chromium in this experiment here in a simulator, where you get a conventional polythene on the left-hand corner here, 3.5 megarad, 5 megarad, and 10 megarad. If you see the 10 megarad polythene is probably the best with the least amount of volumetrical wear, as well as the least number of particles of all sizes which are present. Now, these are the graphs that all the fellows should know. What are the polythenes available for us with cross-linked polythene? So Smith & Nephew is the 10 XLPE, which is the 10 megarad. If you see the resin, see the second column. The polythene is manufactured by 2 companies worldwide, and its available is 1050 or 1020. Most of the companies will have to use that resin. The difference is what is the total dose of radiation that has been used. So both Smith & Nephew uses 10 megarad, the Zimmer Longevity uses 10 megarad, Depew Ultrex uses 7.5 megarad, Duracell is 9.5, and if you see Stryker X3, which is the submelted poly, which is subjected to 3 megarad irradiation for 3 cycles. So the total dose of irradiation is 9 megarad. You can see who is used gamma and who is used beam. You can see the submelted is either the Biomet or the Stryker, and then you can have vitamin E addition for free radicals. If you got remelted poly, then there is no free radicals left. If you got submelted poly, minuscule amount of free radicals are left, and they can create problems. So you need to understand that. And these are the knees. And the knee, again, another variable is whether the polythene comes out as a compression molded poly, but most of them are now, as you can see, compression molded poly. And the Stryker one, again, is a submelted or annealed poly, 3 times 3 megarad. The Depew XLK is 5 megarad. The Smith & Nephew XLP for knees is 5 megarad. And we now know which will have residual free oxygen radicals and which won't have. So that was about polythene altogether. Now, metal on metal, we need to understand for historical purposes. Most of us have completely stopped using it, although there is a benefit in selected group of patients. When we were introduced to metal on metal, it was very high wear resistance. It favored large diameters, so you had huge femoral heads. It is a self-polishing technology, so initially the bedding in wear might be higher, but once it polishes itself, the self-healing properties came into place. But now we have long in vivo experience of its problem. So I think the head diameters went up for both resurfacing as well as large diameter total hips. Function was better. People could squat, sit on the floor. But unfortunately, the metal on metal ion issue really was a bad one. The decreased tolerances with some of the companies which manufactured their implants led to massive problems of metal ion release, delayed type of hypersensitivity reactions, acute lymphocytic vascular, that is the alveolar lesion, that really created a problem, pseudotumors and failures. And if you see the Australian joint registry, you see there was a higher revision rate for resurfacing when compared to a standard total hip. A caveat was this was not adjusted for age and gender, and in men or below 55 years of age, the resurfacing hip replacement actually did very well. Now, if you see 2 companies, one was the Birmingham hip replacement, which was really the top performing, had very less revision rate as compared to ASR, which was like a shock wave which was sent through the orthopedic arthroplasty community around 2008-9 when the failure of ASR was brought out and all the metal on metal implants were pulled out from the market, apart from the BHR, which continued to function with excellent results. We found out that there were higher incidence of pseudotumors, especially in females, maybe because of smaller head sizes, and if there were component malposition. So if you had edge loading with a vertical hip socket, I think you had more problems as compared to a closed cup. But there is still evidence which supports resurfacing in selected group of patients. You all have seen the story of Andy Murray, the famous tennis player who's had a resurfacing and has gone back to professional tennis. It is a proven design. You need to make sure that you get your inclination and version right in a man less than 60 years of age with good bone stock in selected indications like osteoarthritis with no subluxation and a well-covered head. Large head THR with metal on metal was a problem. It also included a problem of trunnion wear, which was obviously seen more with large head ASR cup with total hip as well. So that was about metal on metal. It was a bad saga in our practice in very early on, and it has now been pulled out. Apart from special request for BHR, you can still get it. Moving on to ceramics. Ceramics are good. We all know that they have an excellent bearing choice. It has got high hardness and high strength. It is scratch resistant. It has got high wettability. What does that mean? If you put a drop of water on ceramic, it is hydrophilic. So it will pull that drop of water and spread over that. If you put a drop of metal water on a metal, it will just form a small bubble and it won't spread on it. So the advantage is, if you understand tribology, if you have an hydrophilic material, it pulls fluid inside the joint and you get fluid film lubrication, which will reduce your wear rate. So that is the importance. High wettability, scratch resistance is much better as compared to if you compare it with stainless steel or even cobalt chrome or even oxidized. It improves lubrication, as I've mentioned to you, and the newer generation of ceramics can be polished to a very, very smooth surface. That will give you an excellent wear resistance. There is no toxicity with ceramics that we know of, and we have an excellent long-term experience with ceramics used in hip replacements. We can go with large diameter heads. So Biolox Forte was the ceramic which was available before the current generation of ceramic that is with us, that is Biolox Delta, and we can use with nearly 36 millimeter heads can be easily used. We will talk about head size in the next couple of minutes. So ceramics are excellent. There are two problems with ceramics. So one is fracture. The first generation of ceramics, the alumina ceramics had a problem of fracture. That was because of low purity and density. The grain size of the ceramic was high, and the manufacturing process was by sintering. So even then, the incidence was only 0.004%. If you see Sedel's work, there were only 13 fractures in 5,500 cases. The Biolox Forte, or the third generation ceramic, was started manufacturing in 1995. Hot isostatic pressing was used for it. The grain size was reduced and proof testing was done. And I think we did much better than the first generation. And the Biolox Delta, or the current ceramic that we use, which is pink in color, which is a combination of alumina and zirconia, along with the strontium oxide and chromium oxide platelets, which will prevent a crack to be propagating. It will act as a shock absorber, and the zirconia itself is actually extremely tough. So alumina is made more tougher by addition of zirconia inside it. And this is what we need to understand with Biolox Delta. You have a combination of zirconia and alumina. Remember, zirconia is not zirconium, or it's not oxidized. Okay, so zirconia is a ceramic. Alumina and zirconia are mixed together. There is a phase of zirconia itself can actually change its properties when it heats up. It goes from what is called as transformation toughening, goes from tetragonal to monoclinic stage. It expands. So if it is mixed with alumina, and if there is a crack which happens in the alumina, the zirconia will expand and block that crack, and it will prevent the crack from propagation. So it will prevent the fracture. So the fracture risk is even gone low with the new generation of Biolox Delta. Most of the companies now have a single manufacturer for Biolox Delta, and that is the Ceramtech. The second problem with the ceramic is squeaking. Squeaking is a high-pitched audible sound, first described in 1950 by Jude with his acrylic hemiarthroplasty, acrylic hip replacement. Incidence range from 1 to 20%. When do we see squeaking? You will see in younger, heavier, and taller patients. And if you have a fractured liner or an impending fracture, if there is a mismatch of a head and liner, and we had failure with the earlier generation ceramic with trident component. And the problem was the trident ceramic insert had a metal elevation, and that probably led to impingement of the neck and the elevated metal liner of that ceramic, and that caused squeaking. And also the stem that was used with the first generation Trident, which was the Accolade 1, which was made up of the TMZF alloy, which is just an alloy for titanium. And that alloy actually acted like a tuning fork. So even if there was a small squeak from the hip joint, the hip stem actually made it more audible. So that ceramic component has now been pulled out. It could be an indication, if you get squeaking, it could be an indication for malposition, version or inclination, or the offset might be incorrect. And as I mentioned, there might be neck rim impingement. So that is all about ceramic and ceramic on ceramic and the problem with ceramics. Now we need to understand what is oxidized zirconium, and that is also known as oxinium. Also is called as ceramicized metal. It is basically metal. So it behaves like metal. It doesn't fracture. It has got the mechanical properties as good as a ceramic without the problem of fracturing. And again, it is wettability is good. As I mentioned to you, if you see ceramics, if you compare the drop on cobalt chrome, it remains, it's not very hydrophilic, that material. But if you see zirconia or oxidized zirconia or ceramic, you can see the drop actually spreads in a wider circle, and that allows you to get fluid film lubrication. Oxidized zirconium again reduces friction against both ultra high molecular weight poly as well as against cartilage. It is harder as compared to cobalt chrome. It is not as scratch resistance as is ceramic. So ceramic is definitely better in prevention of scratch. Oxinium can get scratched, and there are stories of oxinium getting scratched and leading to massive wear, especially in hip joints which have been dislocated. Again, patients who have metal sensitivity, because oxinium does not have any nickel, so you can consider it to be used in a knee replacement. Ceramic obviously doesn't have nickel, so it's not a problem at all. If you see the failure rates at 10 years, this is a very busy slide, but just follow these 3 lines. Ceramic on highly cross-linked polythene, 4.5% revision rate at 10 years. Metal on highly cross-linked polythene, 4.5, and oxidized zirconium is 3.5 at 10 years. So the survivorship for the first decade following a hip replacement, comparatively metal and ceramic have on highly cross-linked polythene have the same result, but the oxidized zirconium has shown slightly better result in the first decade. We still have to see the second decade because we are expecting these younger patients to last much longer. Again, I have mentioned to you this slide, the lowest rate of revision is with oxidized zirconium. That was the Australian Joint Replacement Registry. If you see the Dutch Arthroplasty Registry, again at 5 years and 9 years, oxinium remains the lowest revised bearing choice in this Dutch arthroplasty as well as the Italian arthroplasty registry. We will touch upon tranionosis. It's a large topic, but basically it's a junction between the stem taper and the female bore on the femoral head. So that junction, which will act as a crevice, can lead to corrosion. It is a mechanically assisted crevasse corrosion, and it will allow the metal to degrade away, and metal ions can be released, leading to toxicity and alveol and damage like pseudotumor. The incidence is very less, but both ceramic and oxinium, both are inert materials, so they might be protective towards trunnion problems in hip replacement. So now I think we already talked about the corrosion resistance of ceramics. You take away one one metal away from the corrosion equation. So if there is a titanium stem and a cobalt chromium head, you will get lot of corrosion and tranionosis as compared to if you have an oxinium or a ceramic head. So what are the future strategies? We talked about all the materials that we have. We need to avoid unnecessary modularity. So the modularity that we had at the stem neck and the stem junction has been taken out. You need to do preclinical testing of modular junction. You need to use preferentially a ceramic femoral head if possible, or an oxinium femoral head to prevent tranionosis to a large extent. The taper design needs to be thought about. The dimensions, the surface finish needs to be sorted out as well. Now, the head size, we all know, I'm going to buzz through this. We think now we are not using more than 36 millimeter of heads, especially in a primary THR. In a dual mobility, the outside diameter will be much higher. I'm not talking about dual mobility at all. Increasing the head size will give you better range of motion, less impingement, less subluxation, less risk of dislocation. So the impingement-free range of motion with a larger diameter head, as you compare the green being the 36 millimeter and the orange being the 28, you get more impingement-free range of motion with the larger diameter head. The distance is higher as well. It is the amount of head that needs to be pulled out of the socket, which is obviously better with a bigger head size. It will probably improve you and give you a chance for the patient to achieve squatting or sitting on the floor. As we talked about jump distance, the dead space in the capsule. So if you have a bigger cup, say 56 cup, and if you use a 22 millimeter head, you have more capsular dead space for the head to escape. Whereas if you use a bigger head for that diameter of the cup, I think the dead space will be reduced and the risk of dislocation will go down as well. So I think those are the advantages of large heads. Unfortunately, if you go through the database from the registry in Indian patients, the commonest cup sizes that we use are probably 48-50, and in females probably even smaller. And that is where I think we're struggling with a large head, and dual mobility might solve that problem. With a smaller socket, we might be able to get a 36 millimeter head, better stability, better range of motion. So I think that is what we are aiming for when we talk about a larger head. Probably 36 millimeter, we will talk to Dr. Suri and Pachore sir, Dhanasekar and Dr. Dave. But in my books, I think 36 is where we have now stabilized for a hip solution. So let's now move on. We've seen the Biolox Delta has performed extremely well in the National Joint Registry, the Australian Joint Registry. The fracture risk has gone down. In my opinion, squeaking has not been a major problem in the patient population that we have. And we will take an opinion from the rest of the faculty as well. But my current usage is ceramic on poly, and that is nearly in 95% of patients I will consider a ceramic on poly. So what we need to understand as young surgeon is, in today's information-driven society, companies are unfortunately using direct-to-patient marketing. And it is important as an arthroplasty surgeon or a budding arthroplasty surgeon, you are familiar with new developments. So all the talks, all the things that I mentioned are biomechanics. They might be boring. I love them because I think I can make my decision based on the knowledge that I have, and not from what the medical rep is telling me. What is the beauty of that product that he's explained? I should know what exactly I'm using in my patient to give them a longevity. So you avoid sale gimmicks and give based decisions on your evidence that you have from the reading that you have done. Thank you. Thanks, Dhanashek.
Thank you, Mahesh.
Thank you, Mahesh. Nice lecture. You covered everything about bearing.
Dr. Raja, before we take the questions, just quick announcement. The next talk, the lecture session is on 7th of October. Dr. Parag Sancheti and Dr. Pradeep Punus, they are going to be the speakers. Those who are already here at on this lecture program, please pass on this message to your colleagues. The top faculties from all over India are spending a lot of time and efforts to give us this good lecture program. Please spread this message. Tell your colleagues to maximally join in this lecture program, which is free. Sitting at home, you can learn from these experts, those who have really been taking time out and request on our request coming to give this lecture. So please do that. The 7th of October is the next program. Parag Sancheti and Pradeep Punus. We can take over the questions now. Dr. Raja.
So what is the go-to bearing in current scenario, Dr. Mahesh? What is the ideal bearing?
For me, I think I have come down to ceramic on polyethylene as the bearing of choice for my patients, going through the literature and finding that there is a balance that I have. The results have been excellent as well. And definitely for me, it remains the bearing of choice.
Any specific indication for ceramic on ceramic in your case, where you would certainly like to use that only?
I mean, in very, very young patients in their 20s or even less than 20s, probably ceramic on ceramic with the reduced amount of wear rate as compared to ceramic on poly. So the ceramic on ceramic wear rate is probably the lowest that we have. The third generations, the Biolox, the fourth generation, the Biolox Delta, the fracture risk is low as well. So I think that is the patient group where I would consider using a ceramic on ceramic.
I think
Mahesh, to add this.
Yes, sir.
Mahesh.
Yeah, I can hear you, sir. Pachure, sir.
Mahesh.
Yeah.
Can you hear me?
Yeah, we can hear you, sir.
Mahesh, for you, because you have started a robotic surgery for a ceramic, because they don't tolerate more than 5 degrees of malalignment to have a problem with ceramic. So you have an excellent tool with you. I think for younger people, that should be very ideal to use a ceramic on ceramic.
Yeah.
Because you have an excellent tool.
So
I completely agree. You can actually control your inclination version perfectly. You can achieve a combined anti-version. So I think that would be an ideal mix. Unfortunately, the company which sells the robot doesn't have a ceramic on ceramic.
Also, I think the other benefit is you are able to look at the impingements.
Yeah. That is just wonderful. Yeah.
So the recent update and probably the recent ISHKS meeting at Hyderabad, the conclusion was the go-to bearing is ceramic on poly. And the added risk with ceramic on ceramic, I think it's not preferred anymore. I used to do a lot of ceramic on ceramic. I think Dr. Suri also would have had this experience. But now the present recommendation is to use a ceramic on crosslinked poly, which has a good wear rate as comparable to a ceramic with ceramic. What is your take on that?
You are asking me, Dhanasekar?
Yeah, both you and Dr. Suri.
Yeah, no, I have already answered that. Again, as I said, my go-to bearing. I want to hear from Suri as well.
Yeah, I think I also agree with the better polys with a much better wear rates. A 36 ceramic on poly probably is the go-to bearing. Very young, yes, you may consider, but then probably at today's game, I will not do it without probably using technology, so far as ceramic is concerned. My only other concern is also, about the 3 points Mahesh had made. One about dual mobility as a routine primary in the small cases. After all, in the earlier times, even a 28 with a 48 did not have a high dislocation rate. So long as, and probably we are much better off in terms of alignment compared to what we were about 25 years ago. We did a lot of ceramic on ceramic, everything, but then basically the pendulum slowly starts shifting. The more you realize that how exacting, how precise you have to be in terms of orientation, avoiding impingements and other things. Your probably enthusiasm to use that is a little less, but not to discount the benefits, certainly.
Yeah, I agree with Suri that dual mobility is still got a big question mark in young patients. So I think especially the younger surgeon should understand that dual mobility is not a substitute for poor technique. You need to get your components right. You cannot rely on dual mobility to take you out of or bail you out each time by having component malposition. And we don't know the long-term benefits of dual mobility as yet, especially in younger patients. So I would be very reluctant to use it as a blanket hip replacement in young patients.
So there are a couple of intraprosthetic dislocations we did see, 1 or 2 of them, they're very young, I don't know why. Basically, it will all boil down to malpositioning in a subtle way. So I think this is something we have to bear in mind when we, normally otherwise it's a wave, everybody jumps into a dual all the time. We have to temper it a little bit so that at least.
Any experience in removing a well-fixed ceramic insert?
Sorry, come again, Dhanasekar.
Any experience in removing a well-fixed ceramic insert?
Honestly, I haven't come across a revision of a ceramic unless it is fractured. I haven't come across revising a ceramic hip because of recurrent dislocations or even aseptic loosening, honestly. Suri, what?
Yeah, the removal for what, Dhanasekar?
So I just did a revision. I had a patient with ceramic on ceramic hip replacement where the cup was loose, aseptic loosening of the cup. But there were screws in the socket, so I could not remove the cup end block. I had to remove the liner first, then remove the...
Putting K wires into the slots and gradually tapping it is one way to do it. There is some of them have the tool that is basically you hold the sort of the metal liner, and then basically being a hard on hard, if you keep on eccentrically tapping, they tend to wobble out. The whole capture is only right at the periphery. Beyond that, it's not there. Only the Zimmer now has a dual capture even in the poly, in the continuum and all they used to have. But otherwise, if you take off the periphery, it will come out, Dhanasekar. What was your experience in that?
So I tried these techniques. One technique described as tapping the edge of the metal. So the vibration will pop it out. That's
exactly.
Then they advised to remove part of the metal with a metal bar, then tap the liner with the metal. That also didn't work. I used a metal cutting bar and cut the titanium socket, make a small wedge, removed it, and then try to tap it out. Still, it was not coming out. Then I had to break it and take it out. The disadvantage of breaking is, again, we're leaving a lot of debris inside, which can compromise the longevity of the future polyethylene liner.
Is there anything like a cold welding reported between ceramic and the metal base?
I'm not sure, sir. This is the first time facing this, so it was very difficult task to remove the well-fixed ceramic liner. Whatever techniques described was not working, so finally I had to break it down.
Dhanasekar, I agree. Suri, what the technique, what we are telling about the tapping, it is only for the patients who are, when we are doing a surgery at that time, primary.
Yeah.
The eccentric liner sitting, then it is okay. Suri, it doesn't come out. I don't know whether you remember me and you both were struggling for taking out the ceramic. I think Dhana is right that we have to keep everything ready. It doesn't come out. Those who are already 10 years, 5 years, you want to change, or there is a fracture corner and you want to take it, doesn't come out. So you have to keep all that jugglery around. One thing, Mahesh, the size of the head size, if you go above 32, we don't know this 36 we are using for last 8-10 years. I'm just worried about tendinosis, because there is good evidence that above 32 also the tendinosis chances are going to be slightly on the higher side. So higher side, we have to be careful with this group of patients.
Exactly. So anything, so if you are considered using a 36 head, especially if it's the metal head, then I think the trunnion chances trunnion wear will go up. If you use a ceramic head or an oxidized head, it will be better.
Regarding ceramic and ceramic, this is my personal. Don't take it as a literature evidence. I think people started the problem of speaking from the other part of the world, and that's why this has got a disrepute because of two companies' problems, and the squeaking was the greatest problem in the other part of the country. I think I myself have done a good number of ceramic when I was in Mumbai, and I did publish this, my 20 years result of ceramic. I didn't have a single case of squeaking, even though that time I was not knowing how to align so much perfectly today what we are doing. And I used a single company, which I don't want to mention what company I use, but this is my personal experience of ceramic. I had not a single revision and no squeaking, touch wood. And
that was 28 or 32, correct? That was 28 and 32.
This was, to be frank, it was 20 years back. It was only 28. Sorry.
Correct.
It was only 28 at 20 years back.
I think strangely, Yeah, strangely, even the metal on metal 28, the sandwich which we used to have from Hardy Weber, they worked very well. Somehow they didn't have any troninosis, they didn't have metal debris. Very strange.
Yeah.
There are some published data, the publications and some registries coming. The 32 probably is optimized size.
Yes, they are already NJR.
Yeah,
NJR.
Yeah. But the thing is, I think there is a comparison between the outer shell size and the head size, I think. That is not being factored. We are broadly, blanketly saying 32, 36. But a ratio probably would be a better way to look at it. A Caucasian has a 54, 56 and other heads, but we have only 48, 52. So, and then struggle and fight and then put a 36 probably is not a great idea.
Yeah.
Mahesh,
also at 50, 52 cup sizes, and then when you have this, even in case if it is a poly, if you see, the millimeter thickness of the poly is almost like a shell. You can see through it, 3 millimeters at the low point. It is a matter of big concern. I would rather settle for 32 with a thicker poly.
Yeah.
I agree with you. Sorry.
there is a question in chat box, Mahesh. Is there any disadvantage of oxinium on poly THR?
No, we have talked about advantages. It works very well. The Australian Joint Replacement Registry data is good. Till the first decade, we still have to see for the second decade. I think 5 years have passed since that paper. The only worry with oxinium is if you get a dislocating hip joint, or if there is a scratch on the oxinium as you're trying to reduce it, the scratch will be a disaster. And it can really wear out through the polyethylene rapidly. I have seen a couple of cases where it has gone out through the poly and articulated with the metal with a disastrous result. So you have to take care of not scratching it at the time of surgery itself and making sure that, and if it's an unfortunate case where it dislocates, then it's a problem. But otherwise, no.
And you can't use it with a ceramic.
No.
That is another disaster will we have.
Yeah.
I think we are now having an oxinium dual mobility. Dr. Suri, any opinion on that?
I really don't know. I think that these sort of combinations will keep coming. But I think it has to be weighed against something which has worked for 15 and 20 years. Yeah. See what flight catches the flight, but I think theoretical data, yes, you may talk that there may be, but where has not been a problem. But an intraprosthetic dislocation, if it is going to be less with that, I do not know.
Yeah. The theory with oxinium is basically when you use when you're using a modular dual mobility cup, you are putting in a titanium shell and then you're putting in a cobalt chrome liner inside. So you're unfortunately creating an interface with a large surface area where the titanium and cobalt chromium are going to rub against each other and probably will generate the same trunnion or probably higher trunnion load as compared to a stem and a cobalt chromium head. So I think that is where theoretically I find that it looks good. But as Suri mentioned, unless we have data, it should still be experimental. We've all burnt our fingers or see people burning their fingers with using new implants without the rigorous process of checking it.
If there are no more questions, can we conclude it?
Yeah. Yes. Thank you.
Thank you very much.
Thank you, Dr. Suri and Dr. Mahesh, for a wonderful lectures on behalf of the ISHK Academic Chair and ISHK Trustees. Thank you very much for your time. As we already announced, we have our next meeting. Please log in and attend the lectures. It's going to be very useful lectures for all the FNB students and registrars. Thank you very much. Good night.
Thank you.
Thanks, everybody.
Thank you.
Bye-bye.
Thank you.
Thanks, Dipak.
Bye, Mahesh.
Thanks. Bye-bye. Bye.
Hey, Dipak, thanks. Midnight.
Okay. Thank you. Thank you. Yeah, fine.
Have a good day, sir. It's a morning in here.
Yeah. Thank you. Yes. All right. Thanks.
Bye.